Welcome. My name is Anthony Wong, and I'm at UCLA. I'm just going to spend a little bit of time kind of going over. Do you mind giving me the screen? Um, I'm going to spend a little bit of time going over kind of just very basic principles of looking at images, and then we're going to show you a couple of examples of images that that you might come across and might be useful for you to be able to recognize even early on in your training. So. So first of all, whenever you're, just a little bit of background, my wife is a neuroradiologist, and at some point in your training, you'll probably hear that we as neurosurgeons are better at looking at, images than radiologists are. And like, I can tell you unequivocally that is not true, but we do look at them very differently, and in a very privileged way. So kind of taking a step back, like it's very useful to look at it. Well, how does a radiologist look at it, and how do they look at it differently, and how can I incorporate those skills and those thought processes into what I'm doing? So we start by, what am I looking at? And number one on that is, who is this patient? There's no doubt in my mind that at some point in your in your career you'll find yourself looking at the wrong scan on the wrong patient. And then you start by identifying what type of imaging modality is this, right? Is this an angiogram? Is this an X-ray? Is this an ultrasound? Is this an MRI? Is this a CT scan, or something else, right? And so just start with the very basics, but always do that, especially when you're first starting out. Just take a step back. Like, what is this that I'm looking at? Because you can't interpret it without knowing what you're looking for, and what those things mean. And then second, how am I looking at it? All right. In that I mean, for X-rays and angiograms, the projection. Is it AP? Is it lateral? Is it oblique? Is it one of the other kind of named oblique views? And with regard to cross-sectional imaging, in what plane am I looking at it? Is it axial? Is it sagittal? Is it coronal? Is it something else? And one little point about looking at axial images, right? So CTs and MRIs are cut differently when they're taken in the axial plane. MRIs are oriented, well, this is standard, although it can be changed, but MRIs are generally oriented along the ACPC line for an axial image, whereas a CT is oriented along the supraorbitomeatal line. And the reason for that is to spare radiation dose to the eye. So when you're looking at, people will tell you, and it's absolutely true, it's really hard to compare an axial CT against an axial MRI because they're taken in different slices. Now, once you have identified what it is you're looking at, how you're looking at it, then you read the sequence. So, and I say sequence because, like, when you're talking about an MRI, right, like, which sequence is this will completely determine how you interpret what you see. But then now you implement a search pattern, right? This is, and that starts by, what is normal about it? And what are the normal structures that, and then also what are the structures that we are looking for on this particular sequence? Is it a bone window from a CT? Is it a brain window from a CT? Is it a lung window from a CT? And then is it a T1? Is it a T1 with contrast? Is it a fat saturated T1? Is it a T2? Is it a GRE or a T2 star? Something that that emphasizes calcification or blood, these things. And it's beyond the scope of the talk today, but these are, it is very important to identify normal first and say it out loud. Start by talking your way through it. Very frequently, if you just start naming structures that you know and looking at them, you'll be able to identify what's wrong if you don't immediately see it. Then you say, what is abnormal about it? And then what else is abnormal about it, right? This is kind of addressing the satisfaction of search. And then how do these findings interact with the clinical picture? For sub-eyes, like in terms of acute conditions, basal cisterns, and it's great that it fits in with what Juan and Dr. Bergschneider mentioned, but basal cisterns, you look at those and you'll save somebody's life. I'm going to turn it over to Dr. Colby, and I can just advance the slides for you if you want.
Okay, great. Thank you very much, Anthony. So, hello, everybody. Thanks for taking your time this morning to talk a little bit about neurosurgery. And, reading radiology is a huge subject, and obviously far exceeds the time window that we have today. But just to, build on a couple of the things that Dr. Wong was talking about, the ability to read scans, interpret them, make clinical decisions. This is something you absolutely will need, not just as a medical student or a sub-I or an intern or as a resident, but this is something that you're going to use throughout your career if you decide that you're going into neurosurgery or if you are a neurosurgeon. And all neurosurgeons should be outstanding neuroradiologists. We might not have the formal training of a neuroradiologist, but you really should strive to know the scans and be able to interpret the scans as best as you possibly can, because again, you will be making decisions independent oftentimes of of a neuroradiologist's interpretation. The other thing is, as you're going through your training, try to interpret the scan by yourself first, right? So start off, make your own interpretation, and then it's always good to check it against what somebody who might have had more training thinks about it. And that's a great way to learn. If you could please just go one forward. So, talking about vascular neuroanatomy, I thought was a little bit outside the scope of this talk. So I really just going to focus on blood in the head and the different patterns of blood. This is an example of subarachnoid hemorrhage. So this is bleeding or hemorrhage in the subarachnoid space. We see the typical kind of crab-like pattern of the bright white in the middle. That's distribution of subarachnoid hemorrhage in the basal cisterns. It kind of flares off to the side. That's in the sylvian fissure. And you can see it in the middle, which would be in the inner hemispheric fissure. On this scan, we also see enlarged ventricular spaces or increased CSF spaces. And this is consistent with hydrocephalus, which would be something very common to see with subarachnoid hemorrhage. When we're looking at bright white things on a CT scan, blood shows up, acute blood shows up as bright white, bone shows up as bright white, foreign bodies like a EVD catheter or an aneurysm clip or coils or bullet fragments, all those things show up as bright white. And it's important to be able to differentiate those. If you could please go one forward.
Just wanted to give a 5-minute warning or 6-minute, but just between slides.
Okay, so we'll move quickly. So this is an example of a subdural hematoma. You saw it in Dr. Kim's lecture. We see bright white blood underneath the bone on the right side of the patient's head. Now this is underneath, not just underneath the bone, but underneath the dura. And these hemorrhages are typically hemispheric, meaning they course over the surface of the brain and are bound often by the dural fold. So things such as the falx and the tentorium. If we could go one forward. This is an example of an epidural hematoma. Again, bright white acute blood, but this is blood on top of the dura or epidural. This is oftentimes bound by the sutures in the bone or where the dura attaches to these sutures, often limiting the space. If we could go one forward. This is an example of blood inside the brain tissue itself or intracerebral hemorrhage. We see the bright white, meaning the acute blood. You see a little kind of thin rim of hypodensity around it. This is edema. We do see some mass effect. We're starting to see compression of the lateral ventricle on the left side in the frontal horns. And this is consistent with the mass effect of the bleed. Let's go forward one. This is an example of intraparenchymal hemorrhage in the cerebellum, so a cerebellar ICH. This is multifocal, so we see 2 spots of hemorrhages. Again, you see that kind of darker rim of edema or swelling around it. Multifocal hemorrhages sometimes make you think of tumors or trauma, This just happened to be a spontaneous hemorrhage. And when we see cerebellar hemorrhages, again, things to think of as sub-Is, we worry about compression of the brainstem, a tight posterior fossa, compression of the fourth ventricle or the aqueduct, and all these things can lead to hydrocephalus and brainstem compression. We could go forward one. Sometimes we're looking at the hemorrhage itself. If we add contrast dye to these scans, this is a intracerebral hemorrhage, and then you see on the right side of the screen a contrast dye in the vessels from a CTA, and we see a little dot. If you could just, there should be a little animation showing an arrow. We could go forward one. We see a little dot, and that's called a spot sign. And that oftentimes indicates a little area of acute bleeding or contrast extravasation. Sometimes it represents the source of the hemorrhage, such as a little aneurysm or something like that. But these are one of the features we're looking at to try to predict whether this hemorrhage is going to expand or not. We could go forward one. Moving on to older blood. So on the left side of the screen, we see a subacute subdural hematoma on the right side of the patient's head. The blood here is seen as isodense. If you didn't look carefully, you might even miss it because it looks about the same as the brain tissue itself, but it's something to pay attention to. And as blood becomes more chronic, it becomes darker or hypodense on a CT scan. And oftentimes patients with large chronic subdural hematomas can present with extensive midline shift, which we see here on the right side, because the brain has slowly adapted to this over time. If this were a patient presenting with an acute hemorrhage and this much shift, that patient would be in big trouble. If we could go forward. And there are mimickers, right? So there are other things that appear bright on CT scans that sometimes look like intracerebral hemorrhage. This is an example of a little bright spot in the left medial anterior temporal lobe, which you can see. There's on the CT scan, there's some hypodensity around it, typically consistent with edema. On the right side of the screen, we see an MRI of the exact same thing, showing some hyperintensity around it, which would be consistent with edema. But this didn't happen to be an intracerebral hemorrhage. This is actually a cerebral aneurysm coming off the posterior cerebral artery. So this is an example of a fetal type PCA, meaning it's coming off of the carotid artery and there's not much contribution from the basilar artery. And the pulsations of this aneurysm and the brain aggravation is what's causing the edema. But it's the aneurysm itself which is appearing bright on the CT scan and making it look like a hemorrhage, even though it's not. If we could go to the next slide. And just to finish up, and I think Dr. Wong mentioned this, you really have to look at everything. This is an example. This is a DSA picture, so a digital subtraction angiogram showing what looks like a brain AVM. Okay, we see middle cerebral artery vessels going to a big tangle of vessels and then a vein coursing in. But if we go to the next slide, it's great, we recognize the AVM, but the biggest thing about this picture is that this brain AVM is actually sitting outside of the patient's skull because of just massive hydrocephalus. So when you're looking at these radiology pictures on your rotations or during your residency or during your career, you really want to look at everything and don't miss the forest for the trees, because sometimes the thing that stands out the most first is not actually the most acute problem that you have to deal with. And with that, I'd like to wrap up, and myself or Dr. Wong would be happy to answer any questions that you guys have.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.